Good afternoon, everyone. I'm Patrick Stanley with Shared Action at AIDS Project Los Angeles, and it's about 1 o'clock, so we can go ahead and get started. We have a couple of people from the health department on the line as well, and if you'd like to take a second to introduce yourselves.
Yeah, hi, this is Amanda Reese with the Department of State Health Services. I'm a consultant here with the state. I also have on the line with me Trish Larwood and, hi, Trish, and Ken Rittberger-Suler.
Hi there.
From the University of Texas. And I just want to, oh, and Brittany Doyle is also on the line, but I don't think she'll be able to talk right now. So I just want to say thanks to everyone for registering to be on this call. We know you're very busy, so we appreciate you taking time out of your day to be here. I also want to say thanks to APLA, Patrick, for putting this call together. We appreciate that as well. As many of you know, the community assessment piece of condom distribution is important. It helps set a good foundation for your condom distribution program, and it's also a component of your contract. And so we just wanted to have an opportunity to have a webinar about it today because we're finding that different programs are at varying levels. So hopefully for some of you guys that are doing a really high degree of community assessment, this will help validate or reinforce some of the work that you're doing. And some of you that are just starting out, this will be an opportunity for you to get some tools and ideas on how you can broaden your assessment process. Also today, Patrick's going to talk about the 3 A's a little bit, availability, acceptability, and accessibility. And an email went out a week or 2 ago about some changes to your semi-annual report, and it added a question to address those 3 A's. So today, Patrick's going to talk a little bit about how those 3 A's can be incorporated into community assessment. So again, thank you for being on the call, and I'm going to go ahead and turn it back over to Patrick.
Great, thanks. So again, I'm Patrick Stanley. I'm with Shared Action at AIDS Project Los Angeles. We are a capacity building assistance program funded by the CDC to provide free capacity building assistance, such as this webinar, and that's what we're here today to do. So, as was mentioned, this is a webinar specifically about community assessments for condom distribution. Before we jump into it too much, I just want to do some brief acknowledgments. I'd like to acknowledge APLA, the Center for HIV Identification, Prevention, and Treatment Services at UCLA, the CDC, and the Texas DSHS for making this webinar possible. As was mentioned, today is all about the community assessment. We're going to do a bit of an introduction and then start talking about community assessments for condom distribution, going right into it. We'll spend some time talking about the 3 A's of condom distribution, and then jump into talking about developing community assessment questions, because in our experience, this is where a lot of the process kind of comes to a grinding halt, is developing the actual community assessment. Afterwards, we'll have some Q&A. I'd like to make a couple of notes just before we begin. To ask questions, on the right side of your screen, you should see the webinar options, and at the very bottom, there is a questions tab that you can maximize by pressing the plus sign to the left of the questions word. Here you can ask any questions you have during the webinar, and at the end, during the Q&A, we'll go through these questions and answer them as much as we can. If possible, we'll also open up the lines. I'm not sure if we'll be able to, depending on time, but that may be a possibility as well. If you do plan on speaking or asking a question during the Q&A piece, please dial in. On the right side of your screen, there's the audio tab, and you can select the telephone option to kind of dial in. This webinar is being recorded and will be distributed by the health department. As well, in about a week, we'll work towards distributing additional materials around community assessments. We'll try and get you some additional samples of community assessments that have been done, as well as some supporting materials from this webinar. So let's get into it. We did a bit of introduction already, so let's talk about the community assessment. Community assessments are surveys, interviews, focus groups, some sort of assessment designed to gain information on a specific topic or issue, in our case, condom distribution. Your community assessment is going to provide you really vital information that can be used to improve your condom distribution efforts. And one of the most important pieces of community assessment is that it gives us a very objective view of our population's needs and how they relate to our program. So why develop a community assessment? I mean, let's take a look at a couple of scenarios. For example, let's say there's a program that distributes condoms to several locations, and we're finding out that condoms at the drop spots aren't being utilized. People aren't picking up the condoms from the drop spots. First off, how are we going to find this out? What systems do we have in place to kind of find this out? And second off, how can this be resolved? Well, how can we get the information we need to make sure that these condoms are being accessed by the community? Another scenario, let's say that condoms are being distributed through HIV prevention programs, and what's not known is that the condoms aren't being used. So that our populations are taking the condoms from our drop spots. They're being distributed at our testing locations, but when they take the condoms home, they're not using the condoms. There are other barriers at work here, and now we're talking kind of about accessibility and acceptability of condoms. And these are the 3 A's that we'll start talking about in a bit. And a community assessment will give us the detailed information on how to solve these issues that are currently happening, but also will give us the information on how to prevent these issues from happening in the first place. And that's what we want to strive towards. So community assessments, they provide vital information to guide your program, and a successful community assessment, well, as I mentioned, it will make your condom distribution program proactive rather than reactive to issues that arise. Many issues that we face in condom distribution work and in the HIV work in general are made worse by the fact that we tend to only address them when the issue becomes a large enough problem that it gets our notice. And one of the goals in general of HIV testing with HIV prevention is that we want to start being more proactive with our work. We want to stop and prevent these issues from arising in the first place. So here we have a roadmap for community assessment. The first step being you want to develop a community assessment. You want to gather the community assessment data, analyze the community assessment data, and finally use that information that you've gained from the community assessment to improve condom distribution programs with the results. So first, let's take a look at the first piece, developing a community assessment. And we're actually going to spend the majority of this webinar today on this first step. So community assessments should focus on the 3 A's of condom distribution. We'll get into that in just a second. There are a lot of different ways you can conduct a community assessment. Most common methods are surveys because they're kind of the fastest method for gathering information. They require the least work on the front end, and it gets you the information as fast as possible. Depending on your experience with your population, your experience with certain methodologies, surveys may not be the best method. For example, you might use interviews or focus groups, depending on the circumstances. But the big piece is that we want to focus on these 3 A's of condom distribution with our community assessment. And these 3 A's are availability, accessibility, and acceptability. And one of the reasons we want to focus on this is that the CDC is now requiring that condom distribution programs are implemented as a structural intervention. The history of condom distribution programs, for many of you who've been working in the field for a long time know, is it was kind of a side project that was tacked on to many of our other activities. It was this thing that we would just drop them off at certain spots. We would distribute it through our activities, but not pay a lot of attention to. And I'm not saying everyone did that, but that was the general environment 5 to 10 years ago, or even further beyond. What's changing now is that the CDC is saying that we want this implemented almost as a program in of its own, like you're funded to do currently. Condom distribution programs become structural interventions when the environment is changed so that there's increased availability and accessibility to condoms, and people are more inclined to use them or accept them. And that's where we get these 3 A's from. And as I understand, you're currently funded to implement one of the following. But a successful condom distribution program is going to address all 3 of these. And there are better ways to address all 3 of these without having to put in a lot of the front-end work on all of them. For example, you can collaborate. If you're really putting a lot of efforts towards the accessibility piece, you can collaborate with somebody who's putting a lot of effort towards the acceptability piece if you have kind of similar issues with similar populations. But before we jump into that, let's talk a bit about these 3 A's a little bit more. So condom availability. Condom availability is when condoms are available in the environment where members of the target population are found. The logic here is that people can't use condoms, obviously, if they're not available. Some examples of popular drop-off spots are pharmacies, using condom dispensing machines, having outreach workers distribute them, putting them out at drop spots, or distributing them through HIV testing programs. If we look at a community assessment in regards to condom availability, some of the topics we want to look at are where does your population engage in high-risk behaviors? Because, of course, the primary thing we want to do is distribute these condoms where most of the high-risk behaviors are happening. Another topic you would want to look at is where would your population like to access free condoms? So even if everyone's engaging in high-risk condoms or high-risk behaviors in one area, if they're not comfortable accessing condoms in that area, you might want to take a look at it in the other end and putting it in other areas. And that's where we jump into condom accessibility. Condom accessibility is making sure that there is unrestricted access to condoms that are available in the environment. The logic behind condom accessibility is that even if condoms are available in the environment, people may not acquire them. They may not take the condoms because of barriers. Some of these could be barriers to using condoms. Some of these could be religious barriers, belief barriers. There are a lot of them out there. Some examples would be free condoms, providing free condoms for low-income people. Because, of course, one of the tenets of condom distribution is that we're trying to distribute these free condoms. And one of the primary barriers that existed before these programs started was people wouldn't use condoms because the price was too high or they couldn't afford the condom. So this is one of the basic issues of accessibility that was addressed with the condom distribution program. We want to make sure that they're available in private locations. So somebody who may not feel comfortable taking a condom in a public spot, such as a bar, would feel comfortable taking it in a more private area, and making sure that they're conveniently located in multiple places. Some topics that you'd want to look at with the community assessment in regards to condom accessibility are, again, where would your population feel safe in accessing free condoms? And how would your population prefer to receive condoms? Some populations are very comfortable just taking condoms from a jar in a bar or a jar in a bathhouse. Other populations or other people may not feel very comfortable for that, so there are ways you can address that, such as providing condoms in free paper bags to at least obscure the condoms. The third A of condom distribution is condom acceptability. And this is one of the biggest A's, because this is when we have norms within a community that support the use of condoms, and the type of condoms are acceptable to community members. And the logic here is that if community norms, if our population's norms don't support condom use, or the types of condoms are not acceptable to the population, people may not use them. Some examples are supportive condom use by opinion leaders and public figures. So if community leaders are putting a negative light on condoms, or if community leaders are not fully supporting condoms, you might see a decline in acceptability in your community as a result. Condoms and other products that are of the type that are popular with the community is also an important issue. And a lot of the times we don't have full control over the condoms that we're distributing to our population. In some cases, such as this, they may be pre-purchased by the health department for distribution. But getting this information from the community assessment is key, because this information can influence future decisions by the health department. Condom acceptability can be assessed and modified by using customer-oriented marketing approach, such as the community assessment. Condoms may be more acceptable if they're more attractive, larger, smaller, tighter, more slick, less slick, textured, smoother color. There are a lot of different aspects to condoms that populations differ and have different opinions on what they prefer overall. So it's important to kind of take a look at this data. Some topics, again, that you might want to look at with condom acceptability are what barriers prevent your populations from taking condoms, and what barriers prevent your population from using condoms after they've taken the condom. Here are some examples of how CBOs, health departments, and the CDC have addressed the 3 A's in regards to the condom distribution programs. For example, with availability across these 3 kind of different environmental levels, on the individual level, we place them in condom machines, use condom bowls, provide them at low cost or for free. At the organizational level, we do 100% condom use policies. So we want to make sure that condoms are used in the area 100% of the time, making condoms available in prisons at the organizational level. At the environmental level, we've made increased federal funds for making condoms available. This actually hasn't happened too much in the recent history with high-impact prevention going into place, and we're seeing a decline in funds overall. But again, one of the main points of doing this community assessment, one of the main points of making condom distribution a structural intervention is we're trying to make the most out of what we currently have. So you want to utilize the money we're given, or the condoms we're given, to their fullest extent. So basically we want to make sure that all the condoms we're distributing are being used and all the condoms we're distributing are taken by our population. And that's why we're doing this community assessment in the first place. So now let's talk a bit about designing a solid community assessment. And here we have one of the basic methodological issues of conducting any survey, any interview, any focus group, is that we have a certain amount of information that we need. I'm sure right now swimming through your heads are we have 10, 20, 30 questions we want to ask. But we always have to balance the information needed with the length of the community assessment. The longer the community assessment is, the less likely the population is to take it. For example, if I hand you a one-page survey, you're much more likely to take that than if I hand you a small booklet that I'm asking you to fill out. One of the ways we can address this issue is with survey design. One of the primary ways we can kind of help balance the length out, but still get most of the information we need, is by designing a really solid survey. And one of the things we can take a look at are how we design our survey questions for our community assessment. What I'm going to go over now are 19 principles that have been used over and over again in research and in the real world that help us to both shorten our survey and gather as accurate information as possible. I'm going to go over these 19 principles kind of quickly in order to save some time. But I'll also be distributing this information out in a handout after the webinar is over, as late as next week. And as well, we'll be providing some supporting materials to these 19 principles as well. First, you want to choose simple words over specialized words. We want to make sure that we're using kind of as easy language for the population to understand. And one of the things we also want to shy away from and not do is do very HIV-specific terminology. Sometimes, and looking outside condom distribution programs, sometimes a very common phrase used on surveys that I've seen is linked to care. Now, of course, a lot of us know what linkage to care is, but if you ask members of the general population what it means to be linked to care, they may give several different answers. And this is because they don't have a general definition of what linkage to care actually means. So instead of saying linked to care, you might want to say, when was the last time you accessed medical care? Or when was the last time you went to see a doctor about your health issues? The second principle is choose as few words as possible to pose the question. It always helps once you design a community assessment to take another look over each of your questions and say, can I shorten this? Is there any way to make this question shorter without sacrificing the information that I'm asking? The third principle is always use complete sentences to ask questions. One of the more common issue I see here is sometimes I'll see number of condoms used in a month as the question. And that may pause the participant and say, well, number of condoms used. Well, when are they asking me this? How are they asking me this? And even though we want to use as few words as possible, we want to make sure we use complete sentences to leave no guesswork on the side of the people taking the community assessment. The fourth principle is be precise with what you ask for. You just want to make sure that you're asking for a very specific, if you're asking, for example, behaviors over a period of time, you don't want to ask them in the past, what barriers have you encountered? Because you may get responses that range from somebody who encountered a barrier to condom use in the last year. You may get people who have encountered these barriers over the last 10 years. And maybe 10 years ago, that information isn't as relevant as it was in the last year or two. So you just want to be very precise with the time frame and be precise with what you're asking for of your population. Also going along with this is you don't want to ask for too specific information beyond the respondent's ability to answer. If you're taking a look at high-risk behaviors and you're taking a look at where your population is frequenting the most, you don't want to ask them, how many times have you been to this bar in the last 2 years? And ask them to remember a very specific amount. What you can do here is, well, first off, because this person's not going to be able to recall the exact number, so they're going to give you an estimate. And then when they're going to give you an estimate, you want to be able to control that as much as possible. So what we can do in a lot of these scenarios is say, Well, how many times have you visited a bar in the last year? 1 to 50 times, 51 to 100 times, 100 plus times. And that controls the estimates. You have more control over the information that you're gathering. The sixth principle is use an equal number of positive and negative categories for scalar questions. Scalar questions are the ones where they're asking, so on a scale from 1 to 5, how do you do this? Or how many times do you encounter these barriers? We want to include an equal number of positive and negative categories because if we include more negative categories than positive categories, for example, so say we have a scale from 1 to 6, they may be more likely to respond with a negative category. So by including an equal number of positive and negative categories, we're making sure that they have an equal chance to respond to a positive and a negative response. The seventh principle is distinguish undecided from neutral by placement at the end of the scale. This is talking about, again, the 1 to 5 scales. 3 on a 1 to 5 scale would be the neutral point. But sometimes they might not have an opinion on the question that you're asking of them. And one of the things that you want to make sure that you know with these questions is the difference between no opinion and neutral. For example, if you're asking how many times they frequented a bar or how likely they are to frequent a bar in the future, and it's a scale from 1 to 5, they may not have an opinion on this because they may never frequent this again. I mean, they may not have even considered this. So it might be important to add a no opinion to the end of a 1 to 5 scale. The eighth principle is avoid bias from unequal comparisons. This is a biggie because a lot of times we frequently ask, how much do you agree with the following statement? And by saying how much do you agree, you're priming the participants. You're basically leaning your responses towards a positive bent. And if you ask how much do you disagree with the following statement, you're leaning it towards a negative response. So you would always want to say in the scenario, for example, how much do you agree or disagree with the following statement? The ninth principle is you want to state both sides of the attitude scale and the question stem. And this goes along with the same principle that I just mentioned. You always want to make sure that you're including the positive and the negative in your questions. The 10th principle is you want to eliminate check all that apply questions. And check all that apply questions are the very kind of eye-catchy questions that we think get us a lot of data with a short amount of space. But check all the apply questions have a primacy effect. And primacy effects basically boil down to respondents to a survey are more likely to answer or check the boxes of the first few boxes than they are the last few boxes. This is because the first few boxes stick out more in their mind because these are the boxes that they read first. So check all that apply questions often give us skewed data. They give us incorrect data. So rather than including a check out of the apply question, even though it might seem like it takes longer by breaking it up into multiple questions, it'll give us better data. So more often than not, you want to kind of refrain from including check all of the apply questions. The 11th principle is develop mutually exclusive response categories. You just want to make sure that the responses that you're asking them to circle are all mutually exclusive and that they could respond to both A and B. They could respond to A, B, and C. And if they could, you would want to include in all of the above at the end of the response categories. The 12th we don't want to worry about too much, but it's asking to use cognitive design techniques to improve recall. And this is basically giving them kind of a frame of mind. So if you really want to ask them their behaviors over the last 2 years, and you're asking them what risk behaviors have they engaged in as a result of visiting this bar, you might want to set their mind frame by asking first, how many times have you visited this bar in the past? What activities have you done at this bar in the past? And then ask them, what high-risk behaviors have you engaged in after visiting these bars? You might want to ask them in the same way, but you can kind of see what we're doing here in that we're setting their mindset with a couple of questions leading up to the question that we really want to ask, because we want to get them in that right mindset. We want to take them back to that moment. The 13th principle is providing appropriate time reference, and here we're just saying that if you want data from the last 2 years, you want to include in the question, over the last 2 years, how many times have you frequented this location? Over the last 2 years, how many times have you used condoms when having sex? The 14th principle is being sure that each question is technically accurate. This is an obvious one. Just make sure that your questions are accurate. So if you're providing information about condom use, or if you're providing information about condoms in a question, make sure that it's correct. The 15th principle is choose question wording so that comparisons can be made with previously collected data. And this is essentially saying don't mix up the way you ask your questions. So if, for example, you're including response scales from 1 to 5 with a series of questions, and then the next series of questions you switch to scales from 1 to 7, that starts to make the survey respondent really guess or second guess their responses, because then they have to think about, well, now I'm changing the way I'm really responding. So whenever possible, try and keep the way you ask questions and your response categories as similar as possible throughout your survey. So the 16th principle is avoid asking respondents to say yes in order to mean no. So basically here, you never want to ask them, so how often do you not agree with the following statement? By asking them to say yes in order to mean no, you might get some people who glance over that and actually answer on the opposite side of how they feel. So even if they feel really strongly about that, they might be tricked with one of these questions into responding the other way. The 17th principle is avoiding double-barreled questions. Here, essentially, you don't want to ask a question that has 2 questions within it. So you don't want to ask, how many times have you driven on the highway and went to the following bars? This is because they could have gotten to those bars through other means, such as bicycling or walking to the bars or walking to the bathhouses or whatever location you're looking at. But they might not have a correct response to this because you're being really specific with that question. The 18th principle is softening the impact of potentially objectionable questions. In our field, especially with an HIV and AIDS, we have a much more lax culture around certain topics, such as sex. And our population may not have that same kind of culture, or they may have different views. But we just want to make sure that we're choosing a kind of politically correct ways to say these questions. If you really know your population and you really know that they prefer, for example, a certain slang word to be used for sex or condom use or whatever, it's fine to use that. But you want to make sure that you're not making that assumption and you're really sure that they're using and really comfortable in using those terminologies. And finally, you just want to make sure to avoid asking respondents to make unnecessary calculations. You never want them to say, if you're asking, so what percentage of times have you visited the bar in the last year, based off of 1 to 50 times, 51 to 100 times, and then they have to convert that over to a percentage. A lot of times you're not going to do this, but you just want to make sure you're aware of this and you're not going to do this. So this was a very brief overview of 19 survey design principles you can use. Again, we'll be providing supplementary materials along this, and this webinar will be provided to you afterwards. A recording of the webinar will be provided so you can review these as well. So now that we know some general kind of ways to develop our community assessment, and as well, at the end of this webinar, I'm going to be jumping into some sample assessments that you can take a look over, both from some information that's been provided by the health department and some other assessments that I've seen in the past done as well. So you'll be looking at those. But now let's talk about gathering community assessment data. When planning your information gathering for your community assessment, you want to make sure to take the following into account. First, your target number of participants in your assessment. Depending on the size of your population, this number can really vary. Smaller number of the survey is gathered can mean that your data may not be accurate or representative of your population. If you only gather 10 surveys for a very large population, those 10 people may not have a representative viewpoint of your entire population. If you're not really sure of an appropriate number of surveys or appropriate number of interviews or focus groups to collect, have a discussion with a program consultant about the right number to collect. It's always important to identify who's going to be gathering the data. Do you have volunteers in the community who can distribute the surveys for you? Are you going to be going and doing outreach yourselves and can distribute the surveys alongside the outreach? Identify what locations you'll be gathering data at. Just like with the number of target participants, we want to make sure that the locations that we're gathering our information at are representative of our population. So in a lot of cases, you're already conducting condom distribution. So you might want to take a look at the places that you're currently distributing these condoms and conduct the surveys there. And finally, you want to think about how long you'll be gathering data. This is something that's skipped a lot, and sometimes we can always think that, well, if we hold off for another week, we'll collect another 10 surveys, we'll collect another 20 surveys. So we hold off for another week, and then we keep on conducting for another week, and we keep on gathering for another week, and it goes on and on. So before you even begin gathering, you want to have a set deadline for how long you'll be gathering data. Depending on the size of your population and the amount of manpower you have behind this data collection, you might want to gather data for 1 week to 4 weeks. And usually 1 to 4 weeks is about an appropriate amount of time to collect the data. A word of caution is that you don't want to use condoms themselves as an incentive to take the survey. And one of the major reasons why is this can lead to its own barriers in accessibility. Somebody who's not really comfortable filling out a survey may just not feel comfortable filling out a survey, and it's fine to not get that person's responses. But what we really want to make sure we're not doing is introducing these barriers to accessibility by requiring them to fill out a survey to get a condom. The third step in conducting a community assessment is analyzing the community assessment data. Now, when we're analyzing community assessment data, we should have an idea of the information that we want already. For example, type of condoms preferred, locations frequented, or the demographics of each location, barriers to condom use, barriers to condom accessibility. We really want to focus our analysis on those 3 A's and what we can do, or what information is out there on how those 3 A's play a role in your community. One thing we can do is look at the data for each demographic separately, as well as a whole. And one thing that, for example, that I've encountered in the past is a program's collected this information, and they said, well, no, we actually don't have any barriers to use. We don't have any barriers to acceptability in our community. The condoms, we're fine. After a while, they found out that, well, no one's still taking our condoms. Or people are taking the condom and saying, you know, no, I've already got a condom from you guys, a week or 2 weeks after they've taken one. And what they found out later was that, well, they started to see kind of a trend in it was one specific ethnicity, one specific race that was giving them these responses. So they took another look at their data, and they saw that it was that one race, that one ethnicity, that had a huge barrier to accessibility and acceptability of condoms. But that barrier was washed out because they just looked at those barriers as a whole, as opposed to kind of honing in on what each population's barriers are. So it's very important to kind of take a look at both as a whole, seeing what maybe there are whole barriers to accessibility or acceptability within your populations. But you might not know if there's a smaller population that's encountering a lot of these barriers. That information can get washed out if you don't take a look at them specifically. You want to identify condom brands that your population prefers. And as I mentioned earlier, even if it's not possible to acquire the most popular brands of condoms now, it's possible that this information can influence the kinds of condoms purchased for distribution in the future. So it's really important to know this information. And finally, you want to both list the most commonly encountered barriers to accessibility as well as availability, and identify how severe each or common each of the barriers are. And you want to identify the areas for the most high-risk individuals. And this is because the next step is improving the condom distribution program with the results. And we're going to use that data to feed back into our programs and improve our condom distribution programs. And this is the overall effect of implementing condom distribution as a structural intervention. We want to continuously collect this data, go through this whole cycle. And I'm going to go back a second and say that this community assessment roadmap, this process, is not a linear process. It's a cyclical process. We want to develop this community assessment, gather the information, analyze the information, and improve our program. Then after a long period of time, we want to go back and develop another community assessment, gather the information again, analyze the information again, and then keep on improving our programs. So community assessment results give us a chance to look at and refine our activities that we're currently conducting. If you're working on accessibility, for example, and you encounter a lot of barriers to acceptability, think about how you're going to address them. And as I mentioned before, this is a wonderful chance to collaborate with other condom distribution programs that are funded in your area and collaborate on either marketing strategies, social communication strategies, social messaging to give to your populations. When you identify the locations of the highest risk individuals, you want to make sure that you're focusing a lot of your efforts on those areas specifically as well. And you want to plan out, well, how will you most effectively distribute condoms at these places? You might notice, for example, that at different locations, each location might have its own barriers to accessibility. Each location might have its own barriers to acceptability. So you want to make sure that you're identifying those barriers by each location, and you're addressing those barriers specifically. Before we jump into questions and answers, I want to go ahead and show you some examples of some community assessments that have been done in the past. And as well, the Texas DSHS has a website specifically for providing community assessment tools and external resources to you guys, if you're not aware of it. The website you can see located above, and we'll be providing this information in a follow-up email as well. And on this page, you'll find a great listing of information, kind of the same information that I've gone over today, a nice summary of it. And at the bottom of the page, you'll find sample surveys and sample community assessments that they've located, they've identified as kind of assessments that you can take a look at and kind of gather or customize or base your surveys off of. One of them, for example, is this. And here's a community assessment survey that was conducted. And here we see that both important aspects to identify are here. This is a great survey because it's listing the instructions and the purpose right off the bat. This is something you might want to take a note of and do yourself, because by identifying the purpose of the survey, you get more buy-in and you'll find more surveys completed by your population. There's a listing of different demographics. And then there are a bunch of questions that list with these community assessments. I don't know if this is not a community assessment specific to condom distribution, but this will give you kind of examples of questions that are looked at with different community assessments and how these are formatted. Again, this information is available on this website and it'll be distributed later on as well. Another example, and the last example I have for sample community assessments, is I printed a lot of the information from this just to make this as general as possible. But here you can see some tailored questions included on this. And this was a community assessment that was done for a very specific population, and it was done for a very small location. So this location had a this community condom distribution program had a very specific reason for conducting this assessment, and they knew going into it the very specific questions they wanted to ask. So here they're asking how often to use the following products during sex, from a scale from 1 to 5, because they wanted an idea of how frequently these were used. Not just whether they were used or not, but also how frequently, so they could base their decisions off of that. And they were also asked how often do the following prevent the use of condoms for their population. They were looking at cost of the condoms, availability of the condoms, their own opinions of condoms, their partner's opinions of condoms. And this is a great question to ask, is very frequently it might be a community leader that's giving the information, but even if a person has total buy-in to taking the condom, and if they go back in the bedroom, they're saying, hey, let's use a condom, and their partner's like, no, you know, I kind of pulled back on this. I don't want to use this because I have my own beliefs. That might be a big barrier, and this program specifically actually identified through this assessment that many people said that very frequently the partner's opinions of condoms introduced a barrier to condom use, and they developed a social messaging strategy around this one specific piece to reduce partner resistance. And what they did, I believe, was they introduced kind of messaging that their population could use, that when in the bedroom, They give them almost kind of like a small pamphlet for coaching themselves on, here are things I can bring up in the bedroom to kind of convince my partner that using a condom is a good thing. That side note aside, other questions they were asking is to their community's opinions of condoms, which of the following brands of condoms they preferred to use the most, which of the following products they use during sex. They also didn't want to just look at condoms, but one thing that they were also curious about was, were they also interested in using lubricants? And what they found as well was that many people who took condoms would not take a condom if a lubricant was not also kind of distributed alongside. And in further community assessments, they conducted an interview seeker series after this, asking more information from the community. They found out that basically, since lubricant was seen as such a high-cost product in that community specifically, and it wasn't that true for the rest of the communities, but this one specific community found out that it was too high of a barrier. So they looked into avenues providing lubricants alongside condoms. And I'm not saying, again, all of these things that I'm going over, especially with the specific assessment, may not or probably will not apply to your specific community. So you want to make sure that, and this is the entire reason for conducting this assessment, is that we want to find out the issues specific to our community, specific to our population, so we can specifically address those issues. And then a bunch of questions on where they feel comfortable accessing free condoms, and they had a listing of the famous bathhouses, drop spots, their own centers in this question. And finally, some demographic questions that they were interested in: their gender, their ethnicity or race, and their age range. With that said, I'm going to go ahead and ask if anyone at the health department has anything to add. And if not, we can go ahead and jump into the questions and answers. Just one moment. And Amanda and Brittany, your lines are currently muted. You'll have to unmute them if you want to speak.
Okay, yeah, we're here. Sorry, we were talking about lube. We just wanted to let folks out there know, if you're developing a survey or questions for a focus group and you want some feedback on them, then we're happy to take a look at them and give you some feedback. Any of the consultants as well as Ken will take a look at those, and we can, tell you what we think. So.
Okay, I am actually not seeing any questions right now from the audience. If you don't have, do you have anything else to add from the health department side?
We're all kind of looking at each other. No, I think you did a great job, Patrick. Thanks again for putting this together for us. We really appreciate it.
Yeah, no problem. And this is also something I'd like to mention, is that this is a service that's available to any CBO or any health department even, as we've always been working with the Texas Health Department on several different cases, is that any agency that's either directly or indirectly funded by the CDC can access capacity building services. So not only do you have your own program consultants available to you, and as they mentioned, they're always open. They're always open to help brainstorm. They're open to help help you develop a great community assessment. But you can also request capacity building assistance, and you can have a discussion with your program consultant about that. If you have, for example, a topic that's really time intensive or really requires a lot of effort, and they might feel that it's important to bring in a capacity building assistance program alongside to help with that. These are free services that are available to you from the CDC. So please make sure you're aware of them and access them. If you have any questions about it, my email is, and actually just go ahead and briefly type up my own email, but we'll be sending it alongside any additional supplementary materials as well. Just hold on one second. I'm just going to make a new slide. My email is pstanley@apla.org, and as well, just through contacting your program consultants or contacting anyone at the health department, you can get in touch with me as well. And like I said, utilize your program consultants, utilize capacity building assistance. It's a free service, and really we're here to help you guys out. Let me double check just in case there are any other questions that I missed. I see that Felicia has a question about the community assessments. Felicia, I'm going to go ahead and unmute your line for a second so you can go ahead and speak. Okay, Felicia, you should be able to speak now. Just one second. Felicia, if you can't speak right now, that's fine. You can either get in touch with us through email or we can do a short call afterwards. Okay. Well, Felicia, okay, you can speak, but we can't hear you. That's fine. So let's get in touch a little bit after this. For everyone else, thank you for participating. If you have any questions, again, ask your program consultants, shoot me an email, and we'll be in touch. Okay, everyone, thank you again, and great work, and I look forward to seeing what you guys do. Take care, everyone.
Underneath.